Mm.
Okay. Thank you everyone for joining. I will do my disclosure that this meeting is being recorded and live streamed. Good to see everybody. Excited for our meeting today. I think it's going to be really awesome. Can everybody hear me okay? Okay, we're getting better at this. And I want to give you a little progress report. In the last couple of weeks, the behavioral health team and I have gotten to do some visits in the field. I want to shout out that we were at New Narrative at the Bridgeview location. Um, and we just had they are doing incredible work providing long-term housing for folks who struggle with severe and persistent mental illness. Um, we were able to learn about the creative approaches for management and supervision that folks have been doing. They've really done a good job of creating a culture of support for employees and mitigated some of the challenges with competing with private practice for their mental health professionals. And so we're going to discuss more of these in a future meeting on best practice, but it was just really great for us to be able to be out in the field and meet with people and see the great work that they're doing. I also want to shout out that we were at Trillium Perry Center's groundbreaking for a psychiatric treatment facility for youth. It's going to be 11,000 square feet. It's going to be a historic investment. And these facilities like these are just so important. Jamie knows that we need places like these and we need the staff to fill them. Trillium Family Services is the sole provider for the full continuum of mental health services for youth age 5 to 24. And they support a staff of 685 employees across Oregon. And we're going to be at a later meeting, we're going to be talking specifically about youth and behavioral health providers, but I just wanted to let folks know those are two places we were able to see in between our last meeting that just builds out the depth and breadth of our work. So today we're going to have our meeting is going to be focused on highlighting the profession types that the council is working on that we've identified as a high risk of turnover. Our last meeting was focused on psychiatric medical professions, and today we're going to learn more about addiction providers. Our next meeting will focus on mental health providers, peers, and then we'll have a youth focus. During this, we're going to have a deeper dive and hear from a series of experts and people with lived experience doing the work on best practices in education and training, and then recruitment and retention. In addition to my incredible vice chairs, I want to thank Eli Kinsley and the council members who lent their incredible expertise to help build out this agenda. Monica Vines, Erica Martin, Van, and Summer. During the presentations, we're going to ask people to hold their questions to the end. And we are going to turn it, and then we're going to have Amy Baker from the governor's office, our behavioral health initiative director, is just going to do a little bit of an overview on substance use disorder and process addiction. After that, we're going to hear from Eli Kinsley, the Director of Operations at Bridgeway Community Health, who is Vice Chair of the Council and leads the Licensing and Credentialing Subcommittee. As the Director of Operations at Bridgeway, Eli is leading to do both addiction care and mental health care. Afterwards, we're going to hear from Dr. Andy Mendenhall, the Executive Director of Central City Concern, who will present on best practices in hiring and retaining substance use disorder workforce, including LMPs practicing addiction medicine. I know that there was some discussion last meeting about LMPs, but for the sake of our discussion here, that's going to be the term we use because that's the term that's the term that people are using to describe what those providers are doing in this medical setting. Then we're going to have a 15-minute break in theory, depending on how we're doing on time. Thanks for everybody for always being flexible about that. And then we're going to hear from Summer Walcott, the Executive Director of Continuum Behavioral Health and Recovery Services, a member of the council, who will talk about best practices in the apprenticeship program. After that, we will hear from Monica Vines, Program Director of Addiction and Counseling and Behavioral Health at Central Oregon Community College. Monica and Robin are two folks who were a part of the HEC report. So we're bringing that expertise straight from from the HEC report into this council, and so we're just happy to have them today. So with that, let's get diving into our agenda, and I'm going to turn it over to Amy Baker, who is going to do a foundational understanding of who these professionals are, how they practice, and general career pathways.
Thank you, First Lady. Yeah, so thanks for the opportunity to present. I want to start out and just define what process addictions are, because that's not necessarily a term that everybody's familiar with. Frequently we talk about not yet, Chad, substance use disorders, and process addictions also describe compulsive behaviors that kind of tie into the same brain reward pathways, the sort of dopamine-driven reinforcement loops. And so the most common process addiction would be something like problem gambling. But if you've spent time within the recovery community, you know that there are others as well, which could include like, and these are behaviors that are significant enough that it ends up affecting things like your personal life, health, relationships, and finances. And so it can include overeating, sex addiction, gambling, and online gaming. Next slide, please. So I'm not going to go over so these are basically the levels of care that exist within Oregon as defined by the ASAM, which is the American Society of Addiction Medicine. I think Eli's going to cover this more in his slide, but I want to just give a brief overview of like what the levels of care are that exist in Oregon, where we find most of our substance use disorder and process addiction staff. In Oregon, largely the predominant levels of care are outpatient, the 1.5, and then also 2.1, which is the intensive outpatient. Next slide, please. And next slide. In addition to outpatient and intensive outpatient, we also have different levels of residential care. Again, in Oregon, that's largely the ASAM 3.1, 3.5, and 3.7. And for withdrawal management, which is another term for detox, largely Oregon has withdrawal management in the 3.7 medically monitored inpatient care. And sometimes we have 4.0 that happens within hospitals. Next slide, please. So those are the settings in which we find our workforce. And now we're going to talk a little bit about like what the different credentialing is for the workforce. Next slide, please. And thank you to MacBo for pulling this information for us, super helpful. So within SUD, you have the CADCR as the sort of entry-level position, and it basically entry-level folks can become a CADCR, and then they have 2 years to get 60 hours of education, and with the expectation that they move to CADC 1, which requires 1,000 supervised clinical hours. And then 150 addiction counseling specific training hours. As those folks gain more experience and more supervision, they might move to a CADC 2. And in order to supervise CADCRs and CADC 1s, you have to at least be a CADC 2 or a CADC 3. And you can see there's an increase in supervised hours, and then CADC requires a master's degree in behavioral health of some type. And that's kind of the folks who are sort of the most experienced and the breadth of education. Next slide, please. So this slide kind of speaks to the how many individuals working in Oregon have become duly credentialed. And with the 6,441 CADCs, about 47% are dual credentialed, and that's with the QMHP, QMHA, LPC, licensed medical family therapist, LCSW, and psychologist. Next slide, please. And then these are the mental health credentials that also have their CADC. And you can see the highest is QMHAs, QMHPs coming in second, professional counselors, and then on down. What I would say based on this data, I would say that there are more people who are dual credentialed than I realized, but I don't know if that's true for other folks in terms of their perceptions as well. Next slide, please. And then lastly, not to forget the problem gambling, the certified problem gambling counselors. Their credentialing system is similar to CADC, but a little bit more rigorous in that the R requires a bachelor's degree or equivalency, and then differing levels of hours and supervisory experience. Next slide, please. And all of this is really in the context of the behavioral health talent assessment. The behavioral health talent assessment essentially called out the fact that we're going to have a deficit in addiction counselors if we don't do something to improve the trajectory. And I think in addition to the talent assessment, I know the First Lady has, and I have as well heard from other providers that they have not been able to fill capacity in residential programs and other programs because of the workforce shortage. So this is a really, really important area to address. Next slide, please. And First Lady, I will leave it up to you whether you want to do questions now or if you want to save those to the end.
We can do them. Why don't we do these we're going to do these for after, let's do questions specific to this first, and we won't wait to the end for these questions. Yeah, Shira.
I haven't read the requirements for this in a while, so I could be wrong here, but isn't it true that for LMFTs, LCSWs, and LPCs, that they only need like 60 additional substance use disorder credit hours to be able to treat people with substance use disorder, but they don't have to register as a CADC. So they can serve this population under their license. But so we may be missing some data here in licensed professionals who were treating this population, but haven't actually like gotten their CADC, because I saw that that's maybe a 7% of like professional counselors, of folks who have like gone to the trouble of actually getting that credential added to their name. So I just wonder about that piece of this picture.
I think that's a good call out, and I might actually ask Van if he's still here to speak to that.
I'm still here. Eric wants to answer that.
Great.
So that is very true. There are licensed mental health professionals that have 60 A&D ed hours that are working in state COA, SUD programs, but not a lot. There's not a lot of licensed mental health professionals that are working as frontline counselors in state SUD programs. But to your point, Shira, there's probably a lot of like CSWAs and licensed associates that have 60 clock hours of alcohol and drug ed. So yeah, that is true. But I don't know if we would call they're not really dual credentialed people. It's a person with 60 ed hours in A&D.
Right. Yeah. It's I guess more of a dual scope person. And if they have 120 clock hours, then they could do SUD supervision. But for our forms, we would require somebody to have an advanced addiction credential, so like a CADC 2 or 3, to sign off for other CADCs. So that is a lot of the LPCs and LMFTs that we have. they come and they get the CADC2 or the 3.
Who's tracking that though? Like if they're licensed providers that don't, do you guys? Because I have like a couple licensed folks that have those clock hours, but I don't think that, but they don't necessarily have the CADC. So MACVO wouldn't know about them.
No, we don't know about them. But like I said,
Okay.
if they want to sign off on supervision hours for a CADC, like a candidate to take their exam, then they would have to have a 2 or a 3. So those would be the ones that we track. But you're right. I'm not sure how they're tracked.
Okay. Good. Okay. That's super interesting. Thank you. Okay, I'm going to keep moving us along. Next, and Eli, you might have something to say here. So next, I'm going to turn it over to Eli Kinsley. He's the director of operations at Bridgeway Health. And Eli kind of has the experience of doing it all. He has a master's from Portland State University. He's a licensed clinical social worker with addiction counseling credentials. He serves as the director of operations at Bridgeway Health, teaches at the PSU School of Social Work, and manages to he has a private practice and then still finds time to serve on community boards in Marion and Polk counties. He also does a little volunteer firefighting on this side. And so, Eli, will you talk about I just want to just hand the floor over to you.
Yeah, thank you. Well, welcome everybody. After hearing it from you, I'm surprised I find the time to do anything somewhere in the mix there. And just to be clear, I am not a volunteer firefighter. I do get paid to do it. I do it in the private contracting world. I never got enrolled through the government part of it, which is a little different. But I do love and enjoy doing it, and I'm excited to just share a little bit about what I do. And then thinking just kind of what, everything that Amy was describing, like I got all of those and somehow I landed to where I am, and I'm here now with this opportunity to present a little bit more about you or about what I do, and particularly around the continuum of care best practice. Can I get that first slide up? So really, I'm just going to talk a little bit about best practice in addiction treatment, and it really does come down to the continuum of care model, which Amy introduced us to. It's an amazing model. It was created through a collaboration, or actually kind of evolved over the years, and it was developed by the American Society of Addiction Medicine, ASAM. Next slide, please. So I'm not going to go into a whole lot of detail about this, but there are 4 broad levels of care: outpatient, intensive outpatient, residential, and what they call inpatient. And Amy talked a little bit about this. This is based off the 4th edition. So what Amy referenced was the 3rd edition, which we're currently in and we're currently using. There is a transition. I just came from a training around the 4th edition ASAM continuum of care model. I'm actually looking forward to it. I don't know when it will be implemented in Oregon, but it was really interesting to kind of see how it's developed and kind of evolved. Next slide, please. So why is it best practices, or why is the continuum of care the best practice? Number one, individual treatment. So when you have folks who are duly credentialed or credentialed to treat multiple or various disorders at the same time, they can provide that individualized care. They can provide a comprehensive approach addressing the multifaceted nature of addiction, particularly as it relates to their medical conditions, psychological conditions, and social conditions. That's why I so value like peers, because they can bring in a certain element to that and really provide the best support an individual needs in a comprehensive way. The evidence shows that there's going to be a reduced risk for relapse if you can provide all of those services within one place and setting instead of referring out. We've seen that doesn't really help. Just logistically, it's challenging for folks. I mean, I just think about transportation, like, oh, I got to go see my mental health provider here, and I got to go see my substance use provider here. It's difficult, it's challenging. We see a lot of better engagement from individuals. If they just get to talk and share their story with one person, that's so relieving instead of have to unpack that multiple times to, virtually strangers. And then if that person doesn't, at least in my experience, if that person doesn't represent you or your identity or culture, it makes it even more difficult. The continuum of care best practice is to provide holistic support. Like, people are more than their diagnoses. They are more than what they're coming there for. They are more than, whatever they've been required to be there for, right? Their crimes or whatever it might be, right? And it's really looking at this person from all of the various things that happen to them throughout their lives and the things that they're currently experiencing in the here and now. And like, how do we provide that holistic support? The research supports that there are also the evidence, we use a lot of evidence-based outcomes. We're looking at and kind of monitoring processes or progress throughout that whole continuum of care. If they started off in a hospital, then they went down into a residential setting, and then now they're in a more intensive outpatient, and they've kind of followed all the way through. The research supports that if you can provide as many services, and particularly contextual support too, throughout all of that, they're going to have more significant positive successes and outcomes. Next slide, please. So what is integrated, and even better practice is kind of what I was talking about, is integrated co-occurring treatment model. It was everything that Amy was describing. Like, there are a lot of duly credentialed folks around. What can we do to support those? We got licensed folks that didn't start off in substance use treatment. I was very fortunate to start off in a substance use treatment center. That was my primary focus coming out of my undergrad program at Chemeketa. I think one of the best things that I learned in all of that, working as a substance use provider, that a lot of other mental health clinicians don't get trained around, is ambivalence. People do not want to be there. They are not ready in that moment. It so much prepared me for the person that's, just been struggling with some mild depression. All of their other needs are met. There's not really a lot of stress going on in their life, but those are more of the less complex cases. But now you bring in somebody that has a long history of addiction, a long history of trauma or mental health condition. You bring those things together, you have a co-occurring conditioning. It makes it significantly more challenging. But the best practice model is to create a space where we can provide that integrated care. So just some quick numbers: 21.5 million adults in the United States do say that they're in condition. Yet only 6% of those with a co-occurring disorder receive integrated care. We need more integrated care. We need more integrated care. And unfortunately, in Oregon, 4 out of 5 Oregonians who need treatment for a substance use disorder do not receive it. I think that's kind of why we're addressing here in this collaboration and all of our individual groups. Like, how do we do that? How do we best support Oregonians who are really struggling and suffering? Next slide, please. So what does Bridgeway do? Bridgeway does exactly what it looks like in there. We have medically managed withdrawal detox. We got our residential care. We do our intensive outpatient if a client is willing to engage that. And then, of course, we provide outpatient services. And then, more importantly, what also wasn't included is that now in the new ASAM 4th edition, there is this emphasis on like providing recovery residences. So what does that look like? That might be an Oxford home. That might be an Iron Tribe home, right? That might be some of those transitional homes that some agencies are already having. Those things are significantly important because at least it provides a structured, safe environment that might potentially be peer-led to support that individual's ongoing success. So those are all integrated in our continuum of care model. And then also what we include in that to kind of really address a lot of those other contextual needs is, of course, the co-occurring care, primary care, and dental care, oral health care. Our dental van's actually parked outside right now in the parking lot, seeing our clients. Hey, if I got a toothache and I have an opioid addiction, chances are if that doesn't get resolved, I'm probably going to relapse. So those just kind of the whole best practice continuum of care model. It's what we've done at Bridgeway. To address a lot of what we see as the gaps in the workforce, we really support all of our clinicians becoming duly credentialed, whether that means they're a QMHA and a CADC, or a CADC and a mental health provider, or a substance use provider and a problem gambling provider. Or if you're like myself and a few others at this agency, you have all 3 of those, right? Because any person walking in that door might have any one of those conditions, and you want to be that best person that can support them in whatever they're experiencing. And so that's what we strive to do here at Bridgeway. Any questions about any of that?
Okay. Any questions? All right. Thank you, Eli. I just want to highlight, the importance of whether or not people are living if it's a mental health condition, if it's an addiction, if it's both, right? Those things are getting in your way of accessing medical care. And so just the importance of when people come, when people are overcoming whatever it is, there's a lot of all these other needs that weren't met. And so the need for wraparound services pretty quickly is so important to their overall health. So thank you so much. Rachel, did you have a question?
I do, if there's time. I would, I'd like to put the question out to the group for working in clinics. When I was in the legislature, we passed policy because I brought together behavioral health and primary care to say, how do we have both appointments in the same day, but only one copay? And based on the conversation, I feel like I remember there being pain points for implementation with federal barriers. But I'm just wondering if anyone on this call has heard about it or been able to implement that. Because I know sometimes we pass big policy and then problems lie in execution and implementation. If nobody has, great, but it would just be good to know. I mean, if somebody has, it would be even be greater. But if no one has, it's fine.
It's okay if they don't.
But I'm fine. I'm looking forward to looking into that, given that presentation, Eli. It made me think a lot about those policies we passed.
Yes.
I have not heard of your policy, Rachel, but I do know that we do everything we can here at Road Community Health to reduce the barriers. And so if somebody can only get transportation for one day, but I think our organization eats one of our sessions.
And that's exactly what was happening in FQHCs
Yeah.
and where I worked, and we were trying to make it so then everybody kind of had to do it, but it'll be interesting. I'll follow up. Thanks.
Yeah, I think the insurance companies are not having it.
I love all the faces.
The work.
Okay. Okay. Perfect. I'm going to keep moving us along. This time we're hoping to have discussion at the end. So what we're going to do with this is do these presentations, couple questions, and then have discussion at the end. I also may not have been clear. We are doing a separate place on peers who also play a critical role in both mental health and addiction, dual credentialed. We're doing who are very much a part of the recovery workforce. Just want to be clear that that is going to be its own meeting. So I don't know if I was clear about that, but I want to say it again, just so people, because it's a critical part of the workforce. So we're going to keep moving along. Thank you so much, Eli. Next, I'm going to turn it over to Dr. Andy Mendenhall, who is the director of Central City Concern. Sorry, who is the president and CEO of Central City Concern, is a board certified in addiction medicine and family medicine with medical training from OHSU and previous experience co-founding an integrated treatment program acquired by Hazelton and Betty Ford. He joined CCC in 2017 as a senior medical director and became the chief medical officer in 2018. He's led the agency's expansion of evidence-based practices while guiding it through COVID before becoming the CEO in 2022. I know thank you very much for joining us today. You all do such important and incredible work around addiction care, and I just want to hand it over to you.
Thank you so much, First Lady. It's an honor to follow Amy and Eli. Eli, thank you so much for the work that you're doing and really doing a great job reviewing the ASAM continuum of care. I want to apologize in advance. There is about a 70-foot mobile crane that's moving outside of these single pane plate glass windows and running at about 90 decibels. So it's making my teeth shake as it's moving, if you see it in the background. A little comedy of errors there. Most importantly, it's great to see some familiar faces and some new faces here. And I have been asked to talk about evidence-based practice, and I'm going to share screen here. And can you all see the screen? Could someone confirm verbally for me?
I can't, but I'm questioning myself.
Not yet, but
You can't see the screen.
No.
Okay.
This is a mental status for me. I'm like, wait, can you guys see the screen?
oh, there we go.
Now you can see the screen. All right.
Yes, we got it.
Who is sharing? Am I sharing? Because I don't think I'm sharing.
Andy, I'm sharing, so just tell me when you
Oh,
want to
that's
go to the
great,
next
Chad. Thank you so much. That's great. All right. I attempted to share and failed miserably. So So I have the privilege of talking about substance use disorders, some best practices, building capacity and expertise in addiction medicine, really, for Oregon. Let's move on to the next slide. I have a pretty robust deck here. It's a little bit of what we're going to talk about. And I have an addition around, concepts for growth and development of the workforce that I'll probably take an aside in the context of the deck. Quick little disclosure slide for you all that reviews my background. If you could advance, Chad, it'd be great. I've been practicing addiction medicine in Oregon for 20 years, which kind of blows me away. I became board certified from a couple different licensing boards. I've practiced in literally all substance use disorder treatment settings except an opioid treatment program. There's a little bit about Central City Concern, and what I will say is that when I joined Central City Concern, I interviewed on a platform of ensuring that we moved this organization in a direction of implementing evidence-based practices. Back in 2017, less than 0.25% of folks with opioid use disorder who were being served at Hooper, that was more than 1,500 people a year at that time with an opioid use disorder, were receiving buprenorphine stabilization. And today, which is shocking, and today that number exceeds 85%, which is in alignment with evidence-based practices. In 2017, across our recovery housing continuum, individuals receiving medication to support their recovery were forbidden to reside within our transitional recovery housing continuum because of the beliefs and the belief system of the housing staff. And now, basically since the end of 2018, we are agnostic to evidence-based practice, and anyone can live anywhere within our housing continuum, especially our transitional recovery housing continuum. I do want to say, and this is relevant to a statement later, I am a very, very modest equity holder and serve in a part-time support role within Boulder Care, who's providing telehealth addiction medicine with practice within Oregon and 9 other states. So I do want to acknowledge that because I think it's relevant to the discussion a little bit later on. Let's move on to the next slide. So the practice of addiction medicine really has a many decades history. And just for brevity, we'll acknowledge Dr. Bob as one of the co-founders of AA in 1935. Although prior to that, there were sanitaria for folks with substance use disorder, alcoholism, stimulant use disorder, opioid use disorder. And it's very interesting. The history was use stimulants to treat opioid use disorder, use opioids to treat stimulant use disorder. And that dates back to, the mid 1800s. As we kind of move ahead, the medicalization and the reluctant acceptance of substance use disorders as medical conditions really began in the 1940s and 1950s. But still with a ton of stigma up to and including my early years of practice, if not to today, depending on who you talk to and what we're talking about. Opioid treatment really began formally in the 1960s with methadone through opioid treatment programs. And addiction medicine as a field was formalized professionally in the 1970s. Education became more formalized and board exams as well. It is relevant to note that in the year 2000, the Drug Abuse Treatment Act of 2000 provided access beginning in 2004 in the United States for the prescribing of buprenorphine for office-based opioid treatment. And one of the real tragedies over the first decade or so of DATA implementation was that there were tens of thousands of physicians who had taken the training, but a trifle of a percentage point actually actively practiced. So that supply-demand access issue really remained, and in some parts of our state still remains. Let's move on to the next slide here. Making good time, which is progress for me. A little bit about addiction medicine being recognized as an American Board of Medical Specialties formal subspecialty. And then there was some growth in fellowship programs, including the one up at OHSU, which has been around for over a decade at this point. in 2018, 2019, 2020, really exciting and really important that addiction medicine really expanded, and the ability for advanced practice clinicians to prescribe buprenorphine became a normalized practice. And there has also been some expansion to include pharmacists and other allied health professionals in the work. And in 2020, the COVID pandemic really accelerated access to telehealth care and some broader flexibility with respect to medication-assisted treatment, MAT delivery. Let's move on to the next slide. So, you know, in Oregon and in the nation, but in particular in Oregon, who can practice what we would refer to as addiction medicine? Well, MDs and DOs and advanced practice practitioners, family nurse practitioners, PMHNPs, and physician assistants. And what's commonly overlooked, and I've always thought about this, I frequently think about this, is, you know, the first MAT that is provided in basically every primary care clinic is tobacco cessation prescriptions. That is medication-assisted treatment, right? And so it's so interesting, and it's been an interesting journey over the last 20 years to compare and contrast the prescription of nicotine-containing products, the prescription of bupropion, and other dopaminergic SNRI agents that help people with tobacco use disorder, right? So it's actually been something that folks do, but somehow it's different when we're talking about buprenorphine. And I think that's really just an important frame shift as we still struggle with access in particular communities and within certain clinics. So we can think about how we define the scope of practice, and by no means do I want to say that this is the gold standard here, but I do want to just identify the set and setting. There are many residential substance use disorder treatment programs that have full-time dedicated staff who are prescribers that will prescribe medication-assisted treatment, will prescribe psychiatric medications. And then there are some that literally cannot afford to have a full-time staff member, and so they might engage a part-time consultant, right? Or they might rely on a co-management agreement with a local primary care provider, or a consultant physician or group within a particular community. In outpatient behavioral health programs that are, you know, state certified, these are, you know, where will you actually see addiction medicine practiced most commonly? You'll most commonly see it practiced within opioid treatment programs, where much of the actual dispensing and care management is driven by our partners in nursing, as well it should be, and with oversight and engagement by prescribing practitioners. Other outpatient behavioral health programs have a variety of different types of prescriber access. Within CCC, we're fortunate to have staff resources that support folks in level 1 and level 2 outpatient treatment by design. So folks have dedicated access, and then folks also have dedicated access through integrated behavioral health prescribing in primary care. So in primary care practices, that's certainly around this region where we saw the greatest expansion capacity within the region over the last 8 years. And I like the term medications to support recovery. The American Society of Addiction Medication, the American Society of Addiction Medicine just prefers the words medicine. You know, it's just medicine. It's just part of somebody's treatment regimen. We don't need to call it anything differently. And there's a couple different categories here: medication-assisted treatment, medications specifically to support opioid use disorders. That would include methadone, buprenorphine, and sometimes naloxone prescribing for folks. And I also want to identify telehealth care. And telehealth care can be a platform that provides group behavioral health and or prescribing with peer-based recovery supports. Depends on the entity, depends on the broader framing, and there are multiple telehealth organizations providing support to patients, more so in the commercial space than in the Medicaid space, but they, you know, I need to acknowledge that set and setting. Before I move on, any comments or questions? I recognize we were going to do that at the end, but I just want to catch my breath and ask if there are any questions about the sets and the settings here. I caught my breath. Let's move on to the next slide, Chad. So addiction medicine in Oregon, there was no publicly available centralized count of board certified addiction medicine specialists, but I got a response back from David Simmons, the Oregon Society of Addiction Medicine president, who told me that at present, there are 181 active members of the Oregon Society of Addiction Medicine. 105 of those are board certified MDs and DOs. The rest are advanced practice clinician associate members. And that's against a denominator of 16,567 licensed physicians in the state of Oregon. So it's a very small number of folks that are board certified addiction medicine specialists. I don't have, and I wasn't able to get a number regarding certified addiction registered nurses, CARN or CARN advanced practice APRNs in Oregon. We're privileged to have all flavors of these health practitioners working for us at CCC, and we recognize that we're pretty unique in that privilege. What we do know is that the OHSU Addiction Medicine Fellowship graduates 4 MDs or DOs per year. The OHSU Department of Psychiatry has addiction psychiatry residents intermittently, and they graduate between 1 and 2 per year. The Addictions Nursing Certification Board issues the CARN and CARN AP credentials, but does not publish any Oregon-specific data. And Oregon regulations allow APRNs and CNSs to practice in addiction treatment settings, but do not require CARN certification for such roles, nor should they, because that would just raise the bar, raise the barrier to receiving those services. Let's move on to the next slide. So we've got some strengths and challenges. OHSU does a really great job for clinicians that are interested and have time and capacity. OHSU provides an ECHO, which is a rural, it's rural or urban access to expertise. They have a consult line. There have been some federal and state investments supporting workforce development, and we have really good regulatory frameworks for medication-assisted treatment and opioid treatment through the OHA, I think with really good oversight. There are some challenges and some gaps here that are identified. We're having this conversation because we know that there are challenges and gaps across the organization. I misspoke, across the state. Within our organization, which is the slide that you're not going to see here, I'm going to take an aside. Chad, could you move to the next slide here? We might conclude a couple things, that there's insufficient treatment access within licensed levels of care in many communities. And I've been on a 20-year journey of seeing improving acceptance of medications and medications for opioid use disorder in supportive recovery. I think the last 5 to 7 years have really seen that pivot with the change in the drug supply, the lethality, and the need to really meaningfully close access. Treatment gaps continue to exist for folks who need access to medication. I know that's part of the purpose of our discussion. And it's been CCC's experience that primary care-based services are needed, and this region has proven that they are the most efficient way to scale services, but they require a level of training, and they also require a meaningful level of support from the organization. I will tell you, the first experience I had with an employer when I recognized that we had a ton of folks in a large volume primary care practice back in 2005, 2006, was my employer said, "We do not want those people sitting in our waiting rooms." And I said, "Who do you think I'm talking about? This is the population that we already have in our waiting rooms." And thankfully that affect has changed. But there are definitely certain environments where the interest in practicing addiction medicine is not fully supported by clinics or employers, or at times health systems as well. Thankfully, that has changed pretty substantially. Chad, let's move to the next slide here. So before I dive into this slide, I was asked to provide a little bit more a little bit more data in terms of what CCC does to recruit or train or retain our workforce. So I'm going to just take a moment before I get to that last slide here. And first, I would say that mission affinity is unequivocally what brings folks our way within Central City Concerned. And we at present are kind of high range in terms of market for our drug and alcohol counselors and our master's level behavioral health clinicians. And we're fortunate to be able to do that because of our federally qualified health center structure and the RAP rate that we achieve thanks to the additional services that we provide across the organization. I will say that for our drug and alcohol counselors and for our master's level behavioral health clinicians, my staff and my leaders have said that our churn and our annualized turn rate is about 15 to 25% over the last year. Prior to that, it was close to 40%. And that churn has really been identified as related to non-managed clinical acuity, meaning when folks cannot get access to that next level of care. And in our world, that's access to holds, civil commitment, inpatient psychiatric hospitalization. The moral injury that that's creating contributes to burnout and contributes to churn in our environment. Workplace safety and violence is another indicator or another driver, pardon me, and violence in the workplace is a driver for churn. And then the broader lack of housing for individuals that we're serving at CCC are all identified as challenges to our organization's retention in this tranche of our workforce. We offer mid-range salaries that are comparable to other community health organizations within the region for our MDs and DOs and our advanced practice clinicians. We have fairly minimal churn with this population, despite the social determinant support challenges and despite the acuity. We do have some challenges with efficiency regarding utilization, and that meaning we have a very high no-show rate for our patients and high acuity. And so we have found that our folks that are later in career or have more training demonstrate better resiliency with respect to, at times, if you will, the chaos associated with a low barrier, high volume type of public health clinic. Just two more comments on this, and then I'll move to my last slide. In our organization, we have an expectation at hire that everyone who is a prescriber will be prescribing buprenorphine and will become an expert in providing behavioral health medication prescriptions, and that includes restarts and continuance, pardon me, of things up to and including clozaril or clozapine. And so we set that expectation at higher. And then the way that we help our folks really achieve success in that space and feel a sense of confidence is that we provide direct supervision of between 30 and 60 minutes on a one-on-one basis of our advanced practice clinicians who are more junior in their training or in their career experience for their first 6 months. And we provide them that supervision around their prescription for medications for opioid use disorder and psychiatric prescribing. It helps that we have team-based integrated behavioral health advanced practice clinicians. So we have a PMHNP for each of our primary care teams. And we simply invest in the time required to help those folks become skilled. And what that does for us as an organization is that it creates a consistency of practice across the board. I know I'm running a little bit long on time, so I'm just going to get to the last slide here in my presentation. Strategies for consideration. Chad, could you bring that last slide back up? Thank you. Oops. The first bullet point was, I think it's really important to not pass laws or legislation that compress or put access to medication prescribing at risk, meaning let's not break the existing network of prescriber service access. And that's all I need to say about that, but it relates to who owns the telehealth services, where are they based, what does that really mean for Oregon? That rural-urban divide is something that's very significant, and I would encourage us to be thoughtful and mindful about any potential impact that legislation would have on creating more restriction in a time of great need. I think a really important strategy regarding addiction medicine practice is to set standards for access for hospitals and CCOs. That's applying a lot of pressure at a time when hospitals and CCOs are screaming for a lot of other reasons, appropriate reasons at times. And a really simple CCO-based evaluation of geographic access and understanding utilization and service engagement of populations with substance use disorder is demonstrated by HealthShare's regional approach to looking at high acuity behavioral health and diagnoses writ large. And it's really easy to just get a background of Medicaid utilization and claims for behavioral health and SUD diagnoses and understand who's accessing what. And do you have enough? And do we set some meaningful standards as at least a benchmark or a place to start? Last but not least, I really believe that in addition to whatever loan repayment incentives potentially look like, I think it's important to invest and expand in echo-based services and training and additional training for prescribing clinicians up to and including free incentivized continuing ed. Bring people in, get them together, host them, right? Pay for their lodging, pay for their transportation. Those types of things that and those types of incentives, I think many organizations are going to struggle over the next couple of years to maintain stipends for organizations. I think it's something that would be of value. I do think that there could be incentivization for rural or marginalized communities. And I used to see personal state income tax abatement for primary care physicians who chose to work in rural Oregon. That existed 25 years ago. I don't know that it exists today. You could do the same thing for drug and alcohol counselors, additional behavioral health folks, and or developing an additional tranche or some form of enhanced educational repayment. So I ran 3 minutes long, I think. I appreciate the extra time, and I hope that folks found this useful and stimulating in a meaningful way. Most importantly, I'm really grateful for the cultural shift that's taken place thanks to a myriad of different clinicians and addiction medicine providers that are driving that change over the course of the last 20 years here in Oregon. And we'll look forward to continuance of those changes.
Fantastic. I want to keep us. This is tricky. I want to keep us moving, but I also want people to get. I want to make sure that people get a break today, so we have a little bit of time in between. So I think what I'm gonna do is I'm gonna. Do folks feel okay about breaking from now to 3? Cutting it a little shorter, but keeping us moving. Okay. So I'm gonna take us to a break. It's not gonna be very long, but everybody keep your screen, turn off your screens, but stay on the Zoom, and we'll see you back at 3. Thank you, everyone, for always being so timely. And a big thank you to Dr. Mendenhall for all of the work that you do. That fantastic. Thank you for the presentation. It was fantastic. And I'm going to keep moving people along, and then hopefully we'll be able to have time for more discussion. So next, I am going to turn it over to Summer Walcott, the Executive Director of the Continual Behavioral Health and Recovery Services. Summer is the Executive Director of On Track Rogue Valley and a licensed professional counselor with over 20 years of experience in Oregon's behavioral health system. Holding an MS in counseling rehabilitation for Portland State, Summer leads On Track's integrated approach to supporting entire family systems with substance use treatment and recovery services in Jackson and Josephine counties, and serves as the Vice President of the Oregon Board for the Oregon Council for Behavioral Health. I am just so excited to hand it over. Summer, please take it away.
Great, thank you. We'll see if I can figure out how to share. I'm much more familiar with Teams. Uh-oh, that's my mess. What can you all see right now?
Like the slides, but not the slideshow view, you know?
Oh, good. But you can actually see the slides, not my entire OneDrive.
No.
Yeah, that's right. We just see the slides.
You did it, Summer.
Okay.
I
You
couldn't
did
figure it
well.
out. Good job.
Yeah, that was okay. So let me see. So yes, we are going through a name change right now, which is why we're On Track and Continuum at the same time, and it's a little confusing. But we are, hold on, I'm still having issues with my layout here. Where is the slideshow?
This is the one thing I was good at. Oh, there you go. I didn't have to be. It takes many of us.
Right, that was exciting. Okay. Anyway, we're in the middle of changing our name, so it's really confusing because we're On Track and we're Continuum, but here we are. So to change screens, let's see. Okay, yep, that works. Okay, so real quickly, just kind of overview of what we have going on here because it all factors into our workforce training program. We are nonprofit located in Southern Oregon, in Jackson and Josephine County. We have about 180 employees right now, and we're spread out across many sites, which is fun for us to manage. Our staffing breakdown, we're about 25 peer support specialists, about 30 CADCs, 12 QMHPs, some licensed childcare center teachers, and then we have about 60 plus direct care staff that are in that work in our milieus and our residential programs. Those folks don't have any credentials, and then a sprinkling of admin facilities and things like that. We are CARF accredited and ASAM certified for our residential programs, CARF for all of our services. And we are pretty proud of our newest addition. That's that we are a risk and connections agency, which is it's a 3-day intensive trauma-informed care blended with anti-racist principles model that all of our employees in the entire organization go through. So that's a really cool addition. Our programs and services, just kind of plowing through really quickly, kind of starting at the lower acuity end. We have our school-based prevention teams. They are Participating with Medford School District in an alternative to suspension program for kids who are caught with substances. If they don't have a substance use disorder, they participate in it's Teen Intervene. It's a problem solving prevention model. And if they do, then they have us for substance use treatment and co-occurring mental health treatment. We have our mobile outreach, intake, and assessment teams. This is a really popular service that we offer where it's not just peers that go out. We definitely have peers that are all over the place, but we also send our counselors out in the community, which really reduces barriers for people as they're getting ready to be released from jail, or if they're in the emergency department or wherever they are. We can get people to them to do an assessment to determine level of care, help them get on wait lists, do things like that. Our outpatient clinics, we have 3 different clinics. We have our largest one is in Medford. Then we have Grants Pass, and then a little outpost in Cave Junction, which is a rural little community out there. All of the sites have outpatient and intensive outpatient for substance use. Our Grants Pass and Medford clinics have integrated co-occurring services for mental health, substance use, and serve teens and adults. And our Medford site, we also have Child Watch, so that people with young kids that are seeking services can have their kids hang out in our Child Watch space while they're receiving services. We have one small program that's for people who have the SPMI or SMI designation with severe mental illness, plus severe substance use, plus forensic involvement. It's really the state hospital, kind of the people who are stuck in that loop with, of getting released from the hospital. They have mental illness and substance use, and they don't fit really well with any with mental health or substance use. So that's a partnership with 5 of us that are all working together to wrap around support for that group. Then we have our 3 residential treatment programs. We have our moms program for moms plus kids under the age of 5. And that one has a licensed childcare center on site. And then our dads program, which is really unique, is for fathers with their children, again, under the age of 5 on site. And then we have an adult program for all genders for residential. We're building out our Latino Latino services continuum that's delivered in Spanish. We have currently everything except residential and mental health. We've struggled to find a bilingual QMHP. But we will have a residential program coming soon, and then we'll have the full continuum available in Spanish as well as English. For housing, we have kind of the range and one of the things that we've identified as really being effective is our emergency lodging program, and that's pre-treatment, early recovery, people who are unhoused and on the wait list for residential treatment or detox. And it's not a shelter, it's single occupancy rooms with, like bathrooms and laundry and like normal things. But they're not required to stop using because we know they need a higher level of care. So it's very stressful to manage. But it is actually really successful. So we have 4 locations of that right now, with a total of 40 single occupancy beds. Then after residential treatment, we have our transitional housing. All of our transitional houses accommodate either single adults or parents with their children. And that's, people stay usually around 6 months when they get out of residential while they're working on finding permanent stable housing. And then we have our second chance affordable housing continuum, which is about 187 units. So that's kind of our whole range of things that we have going on. And then we have our family treatment campus coming soon. This is very exciting. I'll invite you all to the open house. This is This will be open in the fall of 26. It's well underway. It will have everything on one campus designed to treat the whole family system. The moms and dads programs will move there and expand. There'll be a licensed child care center, but we're adding in the component of early childhood intervention. So we'll have child psychiatry, early childhood folks. And then on the other side of the campus, we have the full continuum of outpatient services specifically for families. And our partners with the Oasis Clinic that focus on primary care, pediatrics, prenatal, and MAT, or medication support recovery, will be on site with us. So that whole big thing will be amazing once it's done. But right now it's all just like, 2x4s and torn up concrete. So our workforce training program, it's fairly unique, and it was born out of desperation, like so many things. Basically in 2021, height of the pandemic, all of our services were open in person because our folks don't have home offices and Wi-Fi and things like that. And we were operating with 50% of our positions open across the agency. We couldn't get anybody to work in residential treatment. We needed, twice as many bodies as we had across the agency. So we cooked up some scheme to trick people into working for us, and it worked really well. So we invented our peer and counselor education program, which is basically, people coming in. We needed people to work in residential treatment, and we wanted people who are working in residential treatment to also have a career path and to attract the people who had the mindset of wanting to learn and grow in their role. So we invented this whole thing and set up this training program where you don't need any experience, no credentials. You have to work full-time in one of our programs, and then you can apply to be part of On Pace. And if you're accepted, which basically means that you haven't done anything like sketchy, and you don't have a performance plan or anything like that, you're accepted into the program. Then it's an 18-month process where we provide all the classroom trainings on site. People are paid, they're working full-time, they get full-time benefits, all the classroom trainings are provided, plus the corresponding treatment manual so that people build a professional library. And then they have all the supervision and support they need as they get their hours to become a CADC. So now at this point, we're, several years in, and pretty much every single applicant that we get for all of our office positions and all of our residential positions, they are all people who are applying for this program, which is fabulous, except that then the programs are like, yeah, but can we keep some people? Because it creates this turn in the programs. But it has been a really amazing thing for our staff. So the bare bones basics, you have to have worked in one of our programs for 90 days. It's really low barrier that way. We start a new cohort every 6 months, and it's an 18-month program. So that means we have 3 cohorts going at all times, which can get really tricky to keep track of in my brain. The trainings, so in the first 6 months after somebody's accepted, they continue to work full-time in their program. And so they're still working in residential, swing shift or overnight shift or whatever it is, but their schedules are changed so that they have Wednesdays off, because Wednesdays are our training days. So all of our trainings are on Wednesdays with very few exceptions. So on those days, they are in classroom trainings on site. Some are offered hybrid, but most people are in person attending the class. They get the manual that goes with that class at the same time as they're attending it. And the trainings are actually facilitated by experts across the valley. We work really hard to keep it from becoming about how to work with us, and so that it stays focused on clinical skills. And so when I originally started pitching this to people, it spread like crazy. Pretty soon, like we didn't have a single class for our own people to teach. It was all experts from across other agencies. And so at this point, we have 31 classes and 18 different trainers from outside the organization, because a lot of them have 2 classes. And it just kind of keeps going. So at the end of the 6 months, they've had all the foundation classes that are aligned with MACBO's requirements. And then they rotate into their first clinical placement site. So it's either one of our outpatient clinics or one of our residential programs. They're there for 6 months. During that time, their trainings shift to every other Wednesday, and they're focused more on clinical modalities, and learning different things like motivational interviewing, cognitive behavioral, things like that. And they have a ton of intensive supervision at this point, a lot of support, a lot of coaching and mentoring. At the end of that 6 months, they rotate to the opposite. So if they started in outpatient, then they go to residential, or the other way around, so that they experience the full continuum of and get broad perspective on the different services available. And during one of their 6 months rotation, they have an offsite placement 1 day a week, so that they learn about the network in the community. So they might be at La Clinica, they might be at Community Justice's Transition Center, at a school, something like that. Then we have our graduation ceremonies every March and October, which is really cool, because after 18 months, a lot of these folks, it's the first thing that they've ever really graduated from. And they invite their families, and we make a big thing of it. We have like full-on graduations, and we have one coming up in October for cohort 6. So that's kind of the core structure of the program. It was initially, we had a federal grant that sort of supported it, kind of, but really adds so much work that it's hard to say whether or not we needed that grant. But that's the structure of the program. And the data so far is that it's really working. Cohort 6 is graduating in October. 7 and 8 are in their rotations right now. We have 37 people currently enrolled in the program at various stages. Cohort 9 just met for orientation. And so far, since we started this, 25 people have passed their CADC exam, and all of them except one person passed on their first try, which was really interesting, because before that, a lot of people were really struggling to pass those exams. And so that was a really interesting data point. And the one person who didn't pass was the only one who said that she didn't need to study. So there's that. Here's the demographic data. This is my favorite part of the program. We're in a very white conservative area down here in Southern Oregon. And my on-pace participant data is, we have 19% identify as a member of the LGBTQ community, 27% as a member of the BIPOC community, 23% Hispanic. We have 9% are bilingual. Basically, to be none of the above is only half of the people, which is my nice way of saying not in one of the marginalized communities that are a priority, right? Like half the participants meet one of these targeted populations. And then if you look at lived experience, 94% of the participants either are in recovery from a substance use disorder, identify as having a mental health diagnosis, or both, or were previously unhoused. 67% of the participants were previously unhoused, which is kind of a staggering number when I first realized that. Only 6% of the people in the program don't meet one of those criteria of either, lived experience that would qualify them to be a peer, or being previously unhoused. Um, so that's the data right there. And right now we only have, let's see, 13% that have left the program one way or the other and not become certified that we know of. We do look for all of the participants in MACBO if they're not still with us. Most still are with us and are working in various roles across our organization, but they're also working at La Clinica and the Addictions Recovery Center and other agencies. So it's most people are staying with it and very few are not actually going on to become certified. We also, for a while, were able to offer scholarships for just the training component to community partners using Measure 110 funding. That unfortunately went away for us. But the demographics of our scholarship participants matched our in-house ones. We had, only 8% didn't have one of the lived experience criteria. And it was very similar in terms of people who identified as one of the, a member of a marginalized community. So that was fairly successful, though it had some challenges getting folks from other agencies in. The other thing that we do is that all of our classes are open to outside participants for CEUs at a very low cost. So a lot of times our classes, like the core substance use classes, a lot of times mental health professionals are the ones who are attending those because they want to get their 60 hours to be able to, learn more about substance use. We've had a lot of school counselors attending with our folks, and that's been very helpful. Yes, Taylor.
Oh, just a friendly time check.
Okay. So lessons learned, what worked, what didn't work. Mapping our criteria to mapping all of our classes to MACBO worked really well. So that it's a straightforward match. Offering the trainings twice per year worked really well. So that if people miss one, they have another opportunity. Struggles, it is really costly to have all these trainees in our programs doubled up and getting the amount of supervision that they require. And low wages for our supervisors and managers is a pretty significant barrier because they are not able to, our leadership folks oftentimes don't have as much experience as we would like. And then kind of the finale is the registered apprenticeship is really such it's such a problematic fit that we're not applying for any funding that would require us to continue to do it. And it's mostly focused on, it requires 2,000 hours and it was designed for construction trades. It was not designed for behavioral health where you're the trainer and the employer. And having those two requirements creates so many barriers that it's really, really challenging and not effective. And really, that's it. Our biggest barrier for behavioral health workforce is really pay and sustainable wages, which tie back to Medicaid, and making sure that we can predict that. And so that's that. So thank you.
That is, I'm laughing. I love the save the world and fix everything. Great job. I can't ignore Liz. So let's go ahead.
I just had a quick question. I know it's a new program, but have you guys seen like people go on to then get their master's degree, bachelor's degree, all that kind of stuff after completing this program?
Seeing a head nod.
Yes, we have right now, 4 of our graduates are program managers. They're 2s now, they're KDAC 2s and they're program managers. And 2 are enrolled in a master's program.
This was just, Summer, thank you so much for your fantastic presentation, and just thank you for leading the way. You guys are doing incredible work, and you can tell from how engaged people are that we're like, how do we make this happen? And I just think that so thank you. And it shows, right, that we're continuing to invest in the workforce makes a significant difference. Up and down the line. So thank you so much. I'm going to keep moving us on. So hopefully we'll have time for discussion, is my hope. Next, we're gonna have Monica Vines. Monica Vines is the Program Director of Addiction Counseling and Behavioral Health at Central Oregon Community College. She's going to present on best practices. Monica is a licensed professional counselor with a master's degree in counseling psychology who's worked in mental health since 1997, focusing on trauma, attachment, diversity, equity, and inclusion. She's served as the program director for addiction counseling and behavioral health in Central Oregon Community College since 2007, where she trains future counselors to be ethical, empathetic, and self-aware helpers. And again, Monica also was a part of creating the actual HEC talent assessment. And so we're just so grateful to have Monica's expertise.
Unmute myself. So I appreciate the opportunity to be a part of this conversation. And I'm coming from a very different perspective than I think some of the other presentations today, in that I'm just talking about education from a community college perspective. One of the other pieces, so the program at COCC was started in 2001. I took over in 2007. And since that time, I've also been a part of the Oregon Consortium of Addiction Educators, which is community colleges around the state that get together and talk about curriculum, talk about best practice, talk about legislative issues that might impact our educational components. So we definitely, it is are you all seeing your images in the middle of my screen? No, okay. Okay, so that's my primary focus today, is to talk about just the CADC pathway for from a community college perspectives. As part of the consortium, and also just as part of my search, most of the community colleges in Oregon have some sort of a addiction counseling track, whether it's a certificate or an associate's degree. There's something available across the state. Program size varies, faculty size varies at different institutions. But there is something available at most institutions across the state. So talking about some of the barriers. So one of the things that we have run into here in Central Oregon is that we do not have enough supervisors. We do not have enough CADC2s to provide supervision. We also do not have enough agencies to take on our students. And so they may complete the core content courses, but then they are not able to then get their hours. So it's a barrier moving forward to be able to then sit for their test once they've completed their educational hours. I have some good news in that regard, but I'll wait for that. Rural areas in particular are overwhelmed with not enough providers, and therefore not enough bandwidth to take on students who are new into the field. Student struggles. Students are under-resourced. They often have their own lived experience with untreated mental health challenges or ongoing SUD issues. It's very common to either our student population and or those that are newly entering the field to return to use if they're in early recovery. I've also seen over the years that, and this is just sort of my own anecdotal experience, that students get their financial aid packet, and that can be a trigger to returning to use because they have all of this money that they're not used to having. And but that's an aside. Many have legal history, suspended license, legal fees. Sometimes the suspended license can interfere with their ability to travel to a practicum site. Had a student who, great student, was, but she had a suspended license, and so she had to be able to be within by grading distance of an agency to get to do her practicum or to get her hours. Childcare access and cost, other life factors that they're balancing. So I have most of my students are working either part-time or full-time while they're taking classes. And then cost is certainly a barrier for students. Some community colleges have program admissions, though, as far as I know, most of them are pretty low barrier program admissions. Most of the community colleges do not have a program application. They're open enrollment. Students can start any term. Again, challenges with retention. Students get burnout from balancing life, family, work, and school, having unpaid practicum hours. They get employment prior to completion, which is great, but then they miss out on completing the educational components that they might need to be successful in the long run. And then this is feedback from one of my recent graduates that agencies are not up to date on current research and evidence-based practices. So they're stuck in, this is how we've always done it, therefore we should continue to do it this way, rather than moving forward with, up-to-date kind of curriculums at the agencies. In rural areas, I think so for example, in Central Oregon, Prineville, we have 2 agencies. One's an adolescent residential program, the other is adult outpatient program. Down in Lapine, there's 1 program. And so even if we do have a student that's interested in working in that program, it's an hour drive from Bend to get down to that particular agency, or it's 45 minutes out to Prineville. I have a great placement out at the Warm Springs Community Center, and it's at least an hour, if not more, depending on traffic to get out there. So that's one of the barriers that we're experiencing with our students. Students might decide to take online coursework. Personally, our coursework is all in person, which is great. It's easy, it's accessible, it's lower barrier. And again, what I've heard from my agencies that I work with, that the online training that they might receive doesn't prepare them well for longevity in the field. And honestly, my students really prefer in person. They want that human interaction. They want to be able to ask questions in real time. They want to be able to learn skills with one another and have it really be an experiential interface. Again, anecdotally, I haven't, I don't imagine MACBO doesn't track this. So Eric and Van, you can totally correct me if you think I'm totally off base with this, but again, my students share that often that students who are doing online trainings may have less understanding of dual relationships, higher instance of boundary crossings, boundary violations, and less understanding of self-care, and so higher rates of burnout. So in-person classes also allow for better gatekeeping. I had a student, this was years ago, who he's like, I really want to get back. I really want to get back. He took a writing class. He's like, I love writing, but I've been told I'm supposed to be a counselor, but that's not what he really wanted to do. And so just being able to have those conversations can be really useful for students in finding their actual pathway. Barriers for educators, faculty shortages. I know this is something that was talked about in our last meeting. This is true at our level as well. So it's one piece is not all counselors have addiction education training. So they don't necessarily understand the processes of addiction. And being a counselor, I have lots of people who apply for part-time positions and then two things get in their way. It takes different skill to be an educator than it does to be a counselor. There's just different practices. And the pay, right? The pay is the other main barrier. They can make a whole heck of a lot more money in private practice or even working at their agency than they can teaching at our institution in a part-time basis. So they have to really want to do it and have a passion for it. They can't do it for the money, and that historically, like I have had awesome, amazing faculty that are like, well, I have to take this other job with the county, and it's a 9 to 5, and I don't have any flexibility, and so I lose really amazing faculty in that way. They're doing great work in the community, and it's hard to find that someone who understands the addiction world. Opportunities, one-on-one in community colleges, one-on-one support from instructors and academic advisors, greater depth of training, more time in the classroom, more attention, more feedback, fewer ethical violations. Again, that's anecdotally from my students who've gone through the program. Stronger emphasis placed on self-care and prevention of burnout. Educational steps can build on one another. We have at our institution have peer support courses. We have a CADC certificate. And then we have an associate's degree that supports people doing their CADC 2 and the current pilot program for the QMHAR. I would say maybe 50% of my students transfer to four-year institutions. Again, one of the barriers with that is that a lot of our applied classes transfer only as electives, as opposed to, and so students are having to take additional credits in order to transfer in as a junior, because the specialized courses that they're taking in order to get the skills to be successful in the field. And then a lot of them have intention to go on for a master's degree. I have, probably actually have 3 students currently who've gone all the way through the program, got their bachelor's, got their master's, have started their own agencies and are taking our students, which is amazing. But it takes time and it takes money and dedication for students to be able to do that. Opportunities, supporting individuals with lived experience, find the right pathway for them to give back and help others. I think Summer referenced 94%. I think that's what the statistics was of having some sort of lived experience. I would say that probably 100% of our students have some sort of lived experience or combination of lived experience, and they're passionate about doing this work. They want to do this work. Retention, if agencies hire them after completion of their degree, and their initial practicum hours, agencies are more likely to keep them. I've had that happen quite a bit. And then my good news, my exciting news, as of September 12th, there were 2 community colleges in Oregon out of 29 across the country that were awarded federal grants to support paraprofessionals in the behavioral health field. Our grant was $1.3 million over 4 years, which is super exciting. And 50% of that funding goes directly to student scholarships and stipends, which is great. It follows 18 students each year, which is right now less than 50% of our student population. So it's great, and it's a step in the right direction, and it's not enough. But I think it's pretty amazing that 2 community colleges out of these 29 were from Oregon. Chemeketa was the other college. I think that's pretty cool. And then almost all of our classes, if not all of our classes, have culturally relevant training as part of the curriculum. And we also have a specific course that really delves deeper into culturally relevant training in helping professions. So that was I think I stayed in time. I wasn't really paying attention, I'll be perfectly honest. So that is all I have for what we do at the community college level. Any questions, or give it back to?
No, you can. Yeah, you can go. Monica, thank you so much. That great job. And we're actually going to move into the discussion. So I'm okay. If we have questions specific to this, let's take them now, and then we'll move into a broader discussion. So first, just want to take questions specific to Monica, and then also just want to, community colleges are huge incubators for the workforce. And we have all of our folks that are coming back with lived experience who we know once they get into the practice will be in the practice and stay in the practice, right? But what it means to support them through an educational institution where they may or may not have any previous experience of working in education or of getting any education, and your ability to be in a classroom with others, if you have lived experience, you're a first generation student, is a big deal. Virtual is not for everyone. And so that's also critically important for our community colleges, which are around our state. So thank you so much for the work you do. Van, do you have a question?
Eric.
Yes.
Eric, do you want to go?
Eric, sorry. I can't, whoops.
Oh,
My
right.
bad. It's the wrong
Right.
right person, wrong name. Sorry.
So, so there are 1,765 CADC 2s and 3s. And there are 5,495 CADCRs and CADC 1s. So the current ratio of CADC 2s and 3s to CADC 1s and Rs is about a 1-to-3 ratio. So for every CADC 2 and 3, there are 3 CADCRs and 1s. So it doesn't look like there should be a shortage of supervisors, but we know that there is. And I'm just wondering, Monica, do you have any insight on why there is? Because we have a ton of CADC 2s and 3s that could be supervisors.
Yeah, I think one of the things that I hear from my agencies is that they might have CADC 2s, but those folks do not want to be supervisors. They're not trained to be supervisors. They don't have the skill set to be a supervisor. So they have the credential, but they don't want to take on that responsibility. That's the biggest piece the feedback that I've received. That was one of the pieces of feedback from our advisory board. And so one of my colleagues, former graduate, we did a training to work with CADC's 2s on, that supervision component. And because several of through the county, I think we had 3 participants from Deschutes County Behavioral Health who had their CADC 2s, but they're like, I don't know how to supervise a CADC 1. I don't know how to supervise a CADC-R. So they had the credential. They were told that they were supposed to do supervision, but they didn't actually have the training or experience to do the work. Does that make sense?
It looks like, yeah, it does.
Okay.
That was a great question, and that was a great response. Let's go to, let's do Dr. Menahal, and then we'll come back to Mac, but I want to make sure we.
I wanted to just build on what Monica offered for Slady, and Eric, thank you for calling that question. Monica, everything that you just said is exactly the experience that we're having here at Central City Concern. In fact, we set up I didn't talk about this, but we set up a behavioral health talent academy for recovery mentor peers, QMHA registrants, and CADC Rs, and at an aggregate cost of about $35,000 to $60,000 per student. It included paid wage stipend for the individuals to basically have a working stipend while they were active in doing the work. And we lost our grant-based funding, which was about $1.5 million. And so we're closing the program, graduating our last cohort in December. We'll have graduated a total of 42 graduates over a 15-month period of time in the 3 different buckets of service. And at the end of the day, what we had to do was we had to very specifically hire people who had supervisory experience. They were late career, paying them at the top of a wage class, and give them almost, this is not a group of folks that's also carrying a caseload, right? They're either dedicated doing supervision most of the time, and that's actually how we have set up the bulk of our supervisory roles within the organization is, at a ratio of 10 to 1, 11 to 1. It's basically a full-time role of somebody who wants to do the work, is very skilled at doing the work, and is not only doing the supervision from the perspective of behavioral health, counseling, behavioral health professional maturation, but then is also ensuring that the employee is documenting correctly and demonstrating effective, meaningful clinical standards. And what we have found is that the average graduate really requires a lot of dedicated effort for both. They might have the clinical chops, but really drift when it comes to documentation quality and compliance standards, or vice versa, right? So it really is an investment in professional development that is a sunk cost, right? And not everybody wants that role. So it is definitely a premium skill set. I didn't offer a solution there, unfortunately, except to say we value unicorns to the best of our ability, but that's expensive, right?
Great, thank you. Rachel.
I'm going to build on that and try to have it be a solution. And the how is Summer, because of that great question that was asked and then these two answers. I think in your presentation, you mentioned the challenge of what in my mind right now I'm saying is this pilot program, even though you've done 6 or 7. You mentioned that that was one of the challenges. So if that's a challenge and then City Central Concern had to close it, is there a way that this council recommends that there's support for these pilot studies or support for that supervisial guidance to grow the workforce? Now, I know that means money, and I know we don't have money because we're in this crazy spot as we're trying to fix things. Boulders are coming at us, but like, I just wanted to put those pieces together because Summer, you're doing it and you still are saying there's this challenge, and where can we maybe think of it broadly throughout the state?
Perfect. This is naturally turning into a discussion, which is fantastic. Summer.
Yeah, real quick, I'll just, one of our biggest problem is really that, we've had to increase the wages of our entry-level staff and our CADC ones dramatically. And as a result, we haven't been able to keep pace for middle management and upper management. So there's wage compression, and without having Medicaid rate increases that are sustainable and predictable, we're stuck. And so we just now have had multiple KDAC 2s turn down the supervisory level when they saw what the rate was, because they can make more staying in their current position where they're not salaried. They can make overtime, and the extra responsibility and work compared to what we can compensate them. They're like, are you kidding? I thought y'all made way more than that. We're like, no. So, it really goes back to that core foundation of behavioral health we have to have sustainable funding as a starting point, because we can't pay our managers and supervisors professional salary. And so then we can't get people into those roles.
Okay. Oh yeah, go, Clarissa.
I just wanted to tag on that, not that this is about nurses or nurse practitioners, we did that last time, but there's a very similar stratification on trying to get really well-trained nurses from the hospital into PMHMP programs. They're making as much as I am now, and I can't talk them into signing up for a whole bunch of student loans that they maybe or maybe won't be chosen for student loan repayment programs. So one of my suggestions that I had written down after our presentation last time was, we've got to front load it. We have to offer from Oregon to pay for this education up front to tempt them to go to school to become a PMHNP or a KDAC or, all of these professional, licensing that maybe they're not willing to sign up for the extra stress and education time for because they can make as much. So that was actually one of the things. Thank you, Summer, for mentioning that it's the same for nurses. I do have another comment when we get to the bigger discussion.
Anything else specific to Monica? Otherwise, let's move into that bigger discussion.
I'm going to say one last thing because we know money's going to be really hard coming up. So what are the things we front load with? What are the things that we offer in place of money if we have to get there? And I think maybe we'll have to figure that out potentially.
Okay. Well, and I'm gonna jump in. One of the things I just wanted to ask folks, and part of this discussion is after today, kind of what are people thinking about? What does it look like we're missing? And I'll float something out here. Is I think that we've talked a little bit internally. The supervision piece is a piece that is reoccurring with all of these professions. Is how are we dealing with the supervision? And when we had the licensing presentations, which were great, I also recognize that we're not actually talking about supervision as much. And so what I might put out to folks is that something that we want to have more of a discussion presentation about at the council level in one of our meetings? Would that be helpful as we think, because it's a critical part of the workforce. These people can't become licensed, credentialed, licensed or credentialed without supervisors. And we've discussed why that is so challenging and why having supervisors can be. And so just wondering if people feel like that would be helpful. I don't know what that would look like. We need some time to put it together. But I would put that out in this discussion of like, are there things that people are starting to see that they would like to see in future council meetings? Liz, I'm going to go to you first because I saw your hand first.
Yeah, I was just gonna say I've been talking to a lot of people about like what kind of stuff they want me to bring up here, like my coworkers and stuff, and that's like one of the number one things is supervision hours and how that's counted, and just like a big discussion around that.
Great. I appreciate you, Rachel and Chris. I just want to make sure nobody else who has not spoken yet, has anything that they might want to say first. Like a good social worker. Okay, seeing none. Rachel?
Yeah, I just want to throw in my support for that because with the psych MPs being independent, I keep trying to think about how the supervisory stuff works in this space. And I feel like I'm finally getting to a place with the presentations on CDACs. But I think if anybody else in this group, like me, is not from that world, it will be very helpful to understand that because maybe there's a solution there. And then Dr. Mendenhall, you had mentioned it's a privilege to have nurse practitioners working with you, but it sounds like you very much made a choice. You invested in making sure that they have training when they're first there to get comfortable. And then you even did what many people are doing and made them become medical directors. So I think it's really interesting on how we look at that supervisory piece for sure.
Clarissa?
Just to tag on with Rachel, that also turns into these fellowship conversations for medical providers. So, when we talk about supervision for LCSWs, I'm seeing some parallels with like the difficulties we're having finding preceptors. But then after you're graduated, you're just thrown out there, to kind of to figure it out. And as Dr. Mendenhall mentioned, or somebody, I can't remember exactly who, some people are better at charting than others. I may not be the best at charting, but I really required somebody, even though I practice independently in my first year, to train me. There's no residency for nurse practitioners. We are asking for residency programs, but they have to be paid. We get out of school, we're not going to do this job for free. We have families to support. These are a lot of people who are older. I was, 45 when I graduated my PMHNP school. So we need them to be paid residencies, which is kind of what Dr. Weiner and I were talking about ideas for that last time. One thing I wanted to mention in the scope of the Grand Council that has come up both in our subcommittee and has come to mind multiple times during this council. Dr. Mendenhall, sorry, I keep stumbling over your name. He
Just
had
Andy.
on
Andy's great, Clarissa.
got it.
Yeah,
Andy,
just Andy.
got it. Sweet. He had on one of his slides some ideas for, tax help if you're working in rural Oregon. One thing that I've noticed is Summer and I are here in Medford, okay? Medford is a bowl that services, we are the only place with the Costco and the Walmarts. I used to joke in Ashland when I grew up there that I couldn't buy a reasonable pair of underwear in Ashland. I had to go to Medford, which is 10 miles away, just to be funny about it. But like everybody comes to us. We are servicing very rural communities. If you haven't been to Butte Falls, I recommend that you go and see what rural communities look like. When I was chosen and thankfully chosen, and I'm so grateful that I was chosen for the NHSC student loan forgiveness, I could not apply for the rural loan forgiveness program because I work in a location that is considered urban. And I see Summer nodding her head. Okay, so when we talk about loan repayment in Oregon, since we are primarily rural, it is very important that we do not exclude people who take care of rural Oregon. So I would say that probably 50% of who I see is from a rural community. But I lost out on, I think it was $50,000 that I could not qualify for. I still have $75,000 worth of student loans to pay for, which really stresses me out, but I cannot double dip. I can't apply for the Oregon specifics. So if we had an Oregon program for loan repayment where we were signing people on to stay in Oregon, we were signing on to pay back their loans, and we were giving added bonuses to anybody who takes care of rural Oregon, not where we're located, I think that would be really interesting to a lot of providers and would be a really top class recruitment piece. So thank you.
Thank you. Shira.
Just wanted to add from the behavioral health side that most of the loan repayment programs disqualify supervisors. So because you have to be a direct service provider. So as soon as you take on a supervisory role, you lose access to your loan forgiveness. And so that in itself tells me that we're not valuing supervisors in the way that we should be. And it should 100% not be a disqualifier for loan repayment.
Thank you for that point. That is really helpful. Wait, I'm going to go to Taylor. Always get Taylor.
Oh, just doing a 3-minute time check. We might
I
just
know
have a
we're in a
couple others
3-minute time
left.
check. So but I want to try to get Andy, Liz, can we let's do this. Yeah, let's try to be.
I'll do super fast. Thank you. And thanks for the time check. Somebody said this, I want to just say it back. It would be really interesting to see if community colleges could actually become the repository for the clinical supervision. Could the community college actually have the faculty who are the paid supervisors for the region's staff? And there's an interface between the employer and the faculty that would create an economy of scale that could create a role, and it would tether the education to the practice and potentially even allow for some group cohorting of supervision. Food for thought. Could leverage the existing system and could be low-hanging fruit.
Interesting. Liz.
Sorry, my computer decided to restart. I just wanted to mention that when we were talking about the behavioral health scholar or the loan repayments, the experience that I've seen as far as like at Project Respond in Cascadia is the 3-year program. It is really, really, really hard to get into. It's kind of touted like it's something that a lot of people can get, but in the last 3 years, I've seen like 4 people get it at Project Respond, and they have to reapply like 4 or 5 times before they get it.
Okay, so I think supervision is definitely a future topic that we feels like really need to spend some time on. We just have a minute left. You know all the things, you'll get the agenda 48 hours in advance. Our next meeting is October 9th from 2 to 4. Taylor, is there anything that we need to do before we wrap up?
I'll just do a 15-second subcommittee update, which is everyone is working so hard on action plans in your subcommittee. Thank you. They are seen. We've gotten some great feedback about how to make the template more concise so that you all are focusing your energy and expertise on the strategies piece and not as much the nuts and bolts that I know has been taking up a lot of time. So we're refreshing that to give some additional guidance, but please know that it's your work is being seen, and we're just trying to help provide the right support and structure to make sure that the subcommittee action plans are consistent and that everyone has clear guidance. So in the process.
Okay, well, thank you so much to our presenters today. This has been incredible. And I think I could tell from people's faces we're all learning something. And so again, thank you for the time today. Thank you for everyone for getting through so much information in their amount of times, which is pretty magical every time that happens. I'm just deeply impressed. It's hard to be able to time that out. So thank you. And look forward to seeing you in October. Thanks for all your work on your subcommittees. Great job.
Bye.
Bye.